So there you go. That was nice of me. Okay, so phase mismapping is the first artifact we're going to talk about, and it's otherwise called ghosting, which is obviously classic indication of artifact in that it's something that you see on the images that isn't actually there. Okay, so we can see anatomy outside of the field of view here. Okay, this is ghosting is predominantly or always in the phase direction. Okay, so if you remember last lecture how we had the different phase encodings per TR, those phase encodings, the same phase line in over different times. Okay, so they might be 5 minutes apart. So the subject moves in that 5 minutes or just breathes normally throughout the acquisition process, you're going to get different phase encodings in different positions. Okay, the frequency encoding is all set by the machine. The machine is smart enough to work out that the frequency encoding is in a different position and correct for that. But the phase encoding is not. Okay, so it's important that you understand that any movement within the image or outside of the image in the phase direction will generate an artifact in the phase direction, not in the frequency direction, because that's all contained in a simultaneous echo, but it's in the phase direction. Okay, so if we have a look at this image, we can see that the phase direction is obviously AP. Okay, the frequency direction is obviously left to right. All right, phase direction is AP because we can see that's where the artifacts are. They're in the AP direction. Okay, frequency direction is left right because that's the only in plane. Okay, as we look at the image, that's the only in plane direction that's left. Okay, so we have phase and frequency, and then of course slice is inferior superior. Okay, so we can change, if we're doing an axial image like this, we can change the phase and the frequency direction just by flipping a switch. And you probably saw that when you're on clinic. Okay, however, the slice direction, you can't change. If you're going to do an axial image, you're always going to have the slice direction as superior, inferior in this situation. Okay, so the remedy to solve this is to change the direction of phase and frequency, in which case the phase direction will be left to right and you'll get an artifact outside the field of view. So if this artifact, if you're really interested in the spinal canal and the artifact from breathing out here or the aorta is causing an artifact over the spinal canal, okay, change frequencies, phase and frequency, so phase is left to right, and then the artifact from the aorta that's anterior to the spinal canal is projected left to right. Okay, that way you get to see the spinal canal. Okay, the artifact will not be over what you want to see. Pre-saturation bands, so we know pre-saturation bands null the signal. I think I've looked for this before and I haven't put one in, unfortunately. There's no, that's similar to a pre-saturation band, but it's not. Jumped the gun, wishful thinking. Respiratory compensation, so obviously this is breathing, so we can take a picture every time the patient breathes. Okay, and we'll discuss that when we talk about the abdomen and respiratory gating. Okay. Phase wrap, okay, so this is movement in the phase direction. Phase wrap is when you have a small field of view, okay, and the phase encoding extends outside of the field of view, okay? It will always extend outside of the field of view. So you've got the back of the head here, and you've got the nose and the eyes and the mouth here. Okay, unfortunately, because the phase because the field of view is so small, the phase encoding continues outside, anterior and posterior to that field of view. So information, and Imant should have covered this last year, and I'm just echoing what he would have said. But the occiput, the back of the skull here, will have the same phase encoding as the frontal lobe. Okay, because that phase encoding is in the same position on the sine wave. So if that's got the same phase encoding as the frontal lobe, that the machine's going to think that that occipital lobe is going to be exactly the same position as the frontal lobe, and it's going to position it here. Same as the nose comes out here, okay? That gets the same phase encoding exactly as the cerebellum and the occipital lobe in this case, okay, or the front of the occipital lobe. So the machine says, okay, well, that must be that signal that we acquired from the head coil must be situated on the occipital lobe, okay, or around this area, okay. So the same thing, we can change phase and frequency, okay, so that nose is directed anterior and posterior, and the occiput is directed anterior and superior inferior, and the nose directed superior inferior. So it's not going to be over the brain. Okay. Unfortunately, we're going to have the spine. Okay. And the spine will be over the brain in that case. So we can turn that spine coil off. And that way, even though it gets the same signal or the same phase encoding direction as up here, it won't be projected into the brain because there's no signal coming now, okay? We can also put saturation bands over the spine, so we can null the signal that way. And then again, the machine, any signal that the machine gets from down here, the machine will think comes from here. But if we turn that signal off by putting a saturation band over it, then it's not going to impact up here, which is what we want to see. Okay. Of course, increase our field of view in order to get the nose and the occiput into the field of view. That means that the sine wave is going to cover the whole field of view, not just posterior to the nose and anterior to the occiput, as we've seen here. Okay. And of course, we have the option of no phase wrap, which is just keep the same field of view, but increase the coverage of that sine wave. Okay. And the disadvantage of that is that we're going to get increased signal, which is obviously an advantage from doing that, but it's going to also increase our scan time, which is a disadvantage. Okay. Now, we talked last week, or the other week, we talked about frequency encoding. So obviously frequency encoding is in the frequency direction, okay? And I'm not going to go into it in a great deal, but there's the chemical shift artifact. Remember, the fat and the water precess at different rates, okay? So if they precess at different rates, the machine thinks they're in a different position in the frequency axis. Okay. So what we need to do is, if we decrease the field strength, then they precess, instead of precessing at 440 hertz difference, they precess at 220 hertz difference. Okay. So we decrease, if they're precessing at a different frequency or a closer frequency, we're going to decrease the chemical shift artifact. Okay, so we're going to decrease that line there. Okay, which is an artifact. It's not real. Okay. The other thing we can do is increase the receive bandwidth. Okay, so if we increase the receive bandwidth, we increase the bandwidth per pixel, and then you can imagine that decreases the artifact between the pixels. Okay, so if that's spread out, if 440 kilohertz or hertz is spread over 32 kilohertz pixel, those pixels are going to be, that artifact is going to be less, than if 16 hertz is spread over each pixel. That artifact, that 440 hertz difference is going to be more. Okay. Chemical misregistration. So again, I'm not going to go into the physics of this. Suffice to say, this is an out of phase image. You might have heard, and you certainly will hear in when we talk about the abdomen, that where fat and water, the boundaries of those, you're going to get decreased signal because you're going to have destructive interference. So those two, fat and water, are going to work against each other, and we're going to subtract that difference. So we're going to get no signal or very little signal at those boundaries. Okay. When they work together, we're going to get increased signal. Okay. So this is called an out of phase image. And then an in phase is, I haven't got an image here, but an in phase is when they have constructive. So we're not going to see what's called an Indian ink sign. Okay, we're not going to see that sign. That's going to be constructive interference. Okay, this is related to Dixon's method. This is exactly what Dixon is. Okay, so it's Dixon is in phase and out of phase. Exactly, well done. We have what's called truncation artifact. Okay, so at borders of air and water, we have lines of intensity, okay, clearly seen in this phantom, but also it's very predominant in cervical spine imaging, okay, where you get lines across the spinal cord and you don't know whether those lines are a syrinx or whether those lines are real. Okay. Increase the phase encoding steps is the remedy for this. Now, this is quite important because this is a magnetic susceptibility artifact. We know there's a pin in this shoulder and it's interfering with the magnetic field, the bone. Okay, so the magnetic field where that artifact is not homogeneous. We know over here, and we know that when we scan, we want a homogeneous signal. We want that the intensity or the magnitude of the magnetic field in this field of view to be exactly the same. Exactly the same. But when we put a great big chunk of metal in it, it's not going to be the same. Okay, it's going to interfere with the magnitude of that magnetic field. So of course we know that if that's the case, then protons are going to spin at different frequencies around that area because the magnitude of the magnetic field causing their spin is different. Okay, in which case we have an artifact here. Okay, so we're going to get a great big artifact here called magnetic susceptibility. Okay, so this is magnetic susceptibility covers quite a few different types of artifacts. Certainly the main cause or the most significant cause is metal in the field of view. Ability of the substance to become magnetized results in a change of precessional frequency and phase. Okay, we know that magnetic susceptibility, like susceptibility in the brain imaging, is most pronounced in gradient echo. Okay, better in spin echo and better in turbo spin echo or turbo inversion recovery because we do multiple refocusing pulses. So we put 180-degree pulses in to refocus those spins. Okay, whereas and that reduces the effect of the inhomogeneous magnetic field. If we were to use that magnetic field to refocus those spins, we know that the magnetic field is not the same. So if we're using something that's not the same on something that's not the same, we're going to get a worse artifact. okay? And that's why when we use gradient, we use the gradient to refocus the spins. In gradient echo, we're going to get a worse artifact, more significant artifact, okay? And we want that in the brain. We want that in susceptibility artifact because that's in the brain, because that's going to show us blood. But when we're looking at the shoulder, we don't want that. Zipper artifact. So this is a frequency that's come in because the door's not closed. So someone's on their mobile phone has exactly the same frequency as this line of frequency in the image, and this line of frequency, and this line of frequency. Okay, so close the door, and then we have a Faraday cage that will stop that frequency entering the room. That's what the copper in the Faraday cage is for. Okay, or there might be a light globe that's got a frequency, or there might be a transducer or something that's supposedly MRI safe inside the room that's broken and that's emitting frequency at the same frequency that the machine's trying to detect these images. Okay, so it's going to put frequencies along that line of the image. We've got crosstalk here, so frequencies here are the same. These frequencies here are being flipped, different to what's flipped up here. Okay, so of course these spins are going to be at a different orientation throughout this. Okay, now there is and patient motion. So patient motion exactly the same as phase ghosting. Okay, we can see that the phase direction is AP, which means the frequency direction is left-right, because the slice direction has to be inferior-superior, because we're looking at a slice. Okay, so I've got, please pay attention and read this recommended text. Okay, 4th edition. 5th edition also has a section on artifacts, and that's going to give you a lot of information, and also information on artifacts and information on parameters and trade-off, which is what we learned, what we talked about in our last lecture. Okay, any questions? Right. Okay, onto the shoulder. Moving on. So we're imaging the shoulder. Our next discussion will be on the knee. We get the patient to undress as per the department protocol. We don't undress ourselves. We get the patient to undress, and that was a joke, and remove surrounding metal articles, so the patient's bra. Okay, if the patient's female. We make sure that those clips aren't in the way of our shoulder, otherwise we're going to get artifacts. Magnetic susceptibility artifact, the same as what we saw in the previous shoulder image. Okay, we use the supine. We position the patient supine as comfortable as possible. We use the shoulder coil. Okay, so it's as simple as that. What coil do you use to image the shoulder? The shoulder coil. Okay. Arm in the neutral position. This is dependent on department protocol as well. Some departments like internal, some departments like external rotation of the shoulder, and we'll explain the pluses, advantages, and minuses of each patient position later on. We make the patient as comfortable as possible. Okay, so the sequences here. The sequences, we're going to see, it might be better to go through the images, but we're going to see that a proton density image is very similar to a T1 weighted image. Okay, so a proton density image shows anatomy. A proton density FAT-SAT image shows pathology. Okay, so if I asked you what sequences do you want to do in the shoulder, Some departments do T1 and T2 FATSAT of the shoulder. Other departments do proton density and proton density FATSAT of the shoulder. Okay, we're going to use proton density and proton density FATSAT in our learning, but if I asked you a question like that and you said T1 or T2 FATSAT, I have absolutely no problem with that whatsoever. Okay, I don't want you to say, what would be wrong is if you said a T1 and a proton density axial. Okay, so if you just do those sequences or in 3 planes, a T1 and a proton density, they're going to give you the same information. So they're going to give you anatomical information. So you're not going to get pathological information. And on the other hand, what images do you do for shoulder? And you said proton density FATSAT and T2 FATSAT in 3 planes. That's going to give you all pathological information, but it's not going to give you anatomical information. Okay. So proton density is the same as T1. Proton density FATSAT is the same as T2 FATSAT. Okay, and we'll see that in the images. As far as positioning goes, we go from below the glenoid labrum to above the acromioclavicular joint. Okay, and this is obviously the axial, and we go anterior and posterior to the joint. All right. Of course, if we're querying a lesion in the inferior part of the glenoid labrum, maybe we'd move that down a little bit because they've said nothing about the acromioclavicular joint. We don't really need that in our images if we've got a lesion in the inferior, a labral tear or a tumour in the inferior labrum. Okay, we don't need to get up as far as the acromioclavicular joint. But if we're just doing a routine survey of the shoulder, then we need to get above the acromioclavicular joint and below the glenoid labrum. Okay, again, we're professionals, we need to make those decisions. Size positioning of the shoulder. This is the supraspinatus ligament. Okay, so, tendon, sorry, ligament. This is the supraspinatus tendon. Okay, so we image along the supraspinatus tendon. We image parallel to the supraspinatus tendon. Okay, that's a coronal oblique imaging of our shoulder. Okay, and we do coronal oblique imaging of our shoulder. And there it is there. So we're going to align our slices along that tendon, supraspinatus tendon. We're going to go from behind the joint to anterior to the joint. So we must include the joint and we must include those ligaments that are joining into the humerus. Okay. And of course, there you can see that we include, what have I done? Oh, yeah. I wish I didn't do that now. We include superior and inferior to the shoulder. Okay. Why do we go along the length of the supraspinatus tendon? Okay. Because A, it's a good reference point, and B, you can see that ligament is along, we're imaging along its length. Okay. And so we want to see that supraspinatus tendon all the way along its length until it inserts onto the humerus. Because that's such an important tendon and it's commonly affected to cause requests for MRI of the shoulder, if we don't go oblique to that tendon and we cut it here, and then the next slice we cut it a little bit more, and then the next slice we show it a little bit more, we're going to miss bits, and we're not going to see that whole length of that tendon. Okay, and we're not going to image as a baseline in a baseline plane. Okay, so we always image along the length of that tendon in our shoulder imaging. And then, of course, with our sagittal, we must angle perpendicular to that supraspinatus tendon. Okay, so we're cutting the shoulder in a sagittal position, and you can see you'll be able to get a cross section of that tendon in each of your sagittal images, a nice cross sectional image of that tendon. And of course, as I say, we use the lateral, all the insertion points of the tendons, and at least the glenoid labrum, okay, and the labral structures. Okay, so there's a proton density and a T1 image of a shoulder. All right, and we can see exactly what I said before in that those images look very similar, and they do the same function, or their purpose is the same, and that is to show anatomy. Okay, so we can see the anatomical structures very well in these images. Okay. On the other hand, we can see that the proton density fat sat and the T2 fat sat is very similar. Okay, so believe it or not, proton density can have various intensities of fluid, but the intensities that we use in MSK imaging, the fluid is bright. Okay, so if the fluid is bright and we put on fat sat, we get more signal of the joint structures and we get pathological signal. So these areas of pathology where the body sent edema to is going to be bright. Okay, and that's because fluid is bright on a proton density fat sat and a T2 fat sat shoulder. Okay, so again, you wouldn't need to repeat those. You wouldn't necessarily need to do a proton density fat sat and a T2 fat sat of a shoulder. All right, there's no point because they show you very similar information. You can see that the fat sat on T2, you get a bit more fat sat, okay, and you get a bit more contrast on the T2 versus the proton density, which is always a little bit flatter. Proton densities are usually a little bit flatter, depending on the TR and the TE that we use. Okay. So onto the shoulder. We've got osseous, articular, and soft tissue structures, and this is what you spent the last 3 years learning. So I'm not going to go over it in any great detail. Suffice to say, we've got the humerus, the scapula, the acromioclavicular joint, and all those structures within all those bony structures that are associated with those bony structures. And then we've got, that's how they all show on the MRI. Okay, so you can see a normal shoulder and you can see the difference in intensity of those different sequences of the osseous structures. Okay, we know we've obviously got fat, subcutaneous fat. We've obviously got muscle. We know that bones are bright in MRI when they have bone marrow in them, because the marrow has a lot of fat obviously involved. Okay. However, bone is dark at the cortex because we know that there's very little hydrogen molecules, which is what we image. There's very few hydrogen molecules in the cortex of the bone. Okay, so that's why you're going to get dark areas, dark lines around these structures. Articular anatomy, so we've got hyaline cartilage, labrum, fibrous capsule, bursa, and AC joint. They're all structures that we see really well in MRI because they have hydrogen molecules associated with them. Okay, or at least some of the times, they may have no fibrous, like tendons and ligaments. they don't have fibrous cartilage or fibrous hydrogen molecules associated with them in a normal state. But of course, when they get diseased or when they get ruptured or torn, ruptured and torn, then they will have hydrogen. So that's going to be very diagnostic, okay? Create contrast between the normal and the abnormal tissues. Okay, I'm having trouble with my mouse, but we're going to move on. And of course, you can go through these structures and you can see the normal and the abnormal structures that are associated with these. And you've also got the anatomy slides on your Moodle slides. So as far as pathology goes, we're going to spend probably the rest of the lecture talking about internal derangement. Okay, and internal derangement is mechanical interference, is mechanical disturbance with the joint. Okay, so it's essentially or effectively structures with pathology with or in the structures that are particularly associated with joints. So tears, cartilage, damage, synovial fluid, things like that. So if you have a trauma to the joint, or if you have mechanical damage, is the true definition. If you have mechanical damage to a joint, then that's what's called internal derangement, okay, of a joint, as opposed to tumours, if we're querying tumours or infective processes in a joint. These are going to have different sequences that we're probably going to discuss next time. So the shoulder impingement syndrome is the first syndrome. So repeated impingement of the rotator cuff muscles that pass through the subacromial and subcoracoacromial arch. Okay, so we know if we look at a sort of a sagittal image or a lateral image of this shoulder, we've got the glenoid fossa, we've got the glenoid ligaments, and we've got the labrum. And we've got the acromion and the coracoacromial ligament there. Okay, so that forms our arch. That's the coracoacromial arch. Okay, we know that we've got the humeral head here, and we know that the supraspinatus tendon passes between the humeral head and the coracoacromial arch. Okay, so if this arch becomes inflamed, gets spurs, or there's a decrease in distance between the arch and the humeral head, then we're going to push on that, or that's the supraspinatus muscle tendon is going to be affected as it goes through that space. Okay, and then what we're going to have is there's the space there between the arch and the humeral head. And of course, this is a T2 fat sat image or a proton density fat sat image. And we're having signal in that supraspinatus tendon or around that supraspinatus tendon. I think that's probably a bursa, but that's caused by the very similar interference. Okay, a reduction in that space there causes that tear. Okay, a tear or an inflamed bursa. Okay, so we've got a coronal view or a coronal oblique view of the shoulder. We've got a T2 fat sat coronal oblique view. Okay, proton density, T2 fat sat, and we've got a T2 fat sat of the left shoulder as well. So we can see that damage, okay, as it passes through that tight space there. So rotator cuff tears. How do they form? Through trauma, through attrition, which is just repeated activity, or wear and tear. Through ischemia, we know is loss of blood supply, and we also have through impingement. Okay, so we might have inflamed structures around that supraspinatus tendon. predominantly 40, greater than 40 years old, predominantly men, predominantly dominant arm, and symptoms are shoulder pain, stiffness, and weakness. Okay, so that's how they present. Coronal oblique shows much of the length of the supraspinatus tendon, and that's what I was saying earlier on. We want to do an image or get our coronal oblique image parallel with that tendon as it passes into the humeral head. We want to know the sagittal plane so as we can see that arch and we can see the space between that arch and the humeral head. Axial plane shows the subscapularis muscle and tendon and location of the biceps brachii muscle as defined. So the biceps brachii muscle attaches just to the greater tubercle of the humerus. Okay, and you can see there's interference there, subchondral changes where that biceps brachii muscle attaches. I prefer neutral because we get a lot of motions from the shoulder. Okay, so when we image the shoulder, the patient breathes, and when the patient breathes, they move their shoulders. Okay, I like to do my imaging, if I have a choice, with the hands by their side and comfortable, so as they reduce the amount of motion from breathing and reduce the amount of motion from irritability or when they're not comfortable. Internal rotation, some departments prefer internal rotation. However, the supraspinatus and the infraspinatus tendons are overlapped when that happens. Okay, so when they internally rotate their arm, you know what that is, those tendons are overlapped. When they externally rotate their arm, then the positions of the long head of the biceps brachii becomes too close to the critical area of the supraspinatus tendon. Okay, so any lesion there, so that's what's happened here, and any lesion there, the doctors aren't sure whether it's the supraspinatus tendon or the biceps brachii muscle. Okay, so it's important to distinguish that when you're imaging. If I do a normal image, if I do the patient as in a routine position and I see that, and I see that signal may be coming from either, then I'll repeat it with an internal rotation. Okay, so as I can separate those two and show the doctor that the difference, that whether that is the biceps brachii, whether that is the supraspinatus, or whether it is both. Okay, so that's quite important. And that's all just the position, neutral versus internal versus external rotation. So the signal intensity of a rotator cuff, we know that rotator cuff tendons are all hypointense in all imaging. Okay, so we can see the tendons don't have any hydrogen cartilage. All right, so they're hypointense, or they don't have any hydrogen molecules. Okay, I beg your pardon. So they're hypointense on all weighting, okay, because they just don't have any signal to give off. No matter what pulses you put in, there's no signal there because there's no hydrogen in those tendons and ligaments. However, so all four normal tendons should be displayed as regions of low signal intensity on sequences. So if you see an abnormal rotator cuff, that's because we're going to have high signal intensity on some sequences. And that signal intensity will be high on T2 fat-sat images or proton density fat-sat images because the tear will have fluid in it. Okay, it's the same pathological etiology as all the other pathologies in the body. The body sends edema there when it's torn, and you're going to see it on T2 or pathology weighted images. Okay. If you see it on T1 and proton density sequence images, then there's a chance it's a magic angle phenomenon. Okay, so the protons have rephased very quickly, so short TE scans. There's a chance that it's partial voluming, or there's a chance that it's histologic changes in the tendon. Okay, and we'll talk about that a little bit later, but that's like we class as tendinosis. Okay, so that's the cells, that's a change or interruption in the cells in the tendons. Okay. All right, so types of rotator cuff tears, we've got full thickness or a complete tear through the rotator cuff, or partial thickness, and an incomplete tear that involves the articular or bursal surface. Okay, or an intrasubstance tear. Okay, so there's those three. So a full thickness tear, less than 1 centimetre in the sagittal or along the length of the tendon. Full thickness tear, about 2 centimetres in the sagittal diameter. Full thickness tear is grade 3 and grade 4. Okay, so that's not rocket science. Grade 1, grade 2, grade 3, grade 4, massive full thickness tear and secondary osteoarthritis. Okay. I mentioned tendinous defect. Okay, so that's a tendon when it's filled with granulation tissue and fluid. All right. Retraction of musculotendinous junction from normal 12 o'clock position. So that's with a full thickness tear. So we're talking about a full thickness tear here. Okay. And we can see that in a normal tendon, that supraspinatus tendon will attach or will continue to about 12 o'clock. Okay, or even further as it attaches to the humeral head. Okay, we can see here on this full thickness tear that this attachment has actually retracted. So it's about 1 o'clock to the humerus. Okay, it's retracted and it's bunched up. Okay, so if you see that, of course you can see that there's going to be a full thickness tear there. You don't see that ligament extended across and down towards the insertion. Okay, you see it retracted there. So retraction of musculotendinous junction from normal 12 o'clock position on the coronal oblique. Okay. Let's be particular. You also see fluid in the subacromial, subdeltoid bursa. Okay, and that's what we saw earlier on, that bursa fluid that looks similar to that image that we saw earlier on where the bursa was hyper intense. Okay. Fluid in the glenohumeral joint. Loss of peribursal fat. So we know that we're going to get bursa. We know that we're going to get fat around that bursa because the bursa stops the ligament from rubbing on surrounding tissue. There's a little layer there. Okay, so instead of, if you don't have a bursa, you have friction. If you have bursa, you have a little bit of space. Okay, so you lose that fat in the bursa with a full thickness tear. And of course, you also have muscle atrophy and fatty infiltration. So whenever you stop using your muscles, you have muscle atrophy. You don't use it, you lose it. Okay, and when you have fatty atrophy, when you have muscle atrophy for any length of time, chronically, it becomes to get infiltrated with fats. Okay, and you can see I've got a lovely slide there where this is probably an elderly person. They've had their arm retracted. They've had a fall or something that's full thickness tear. They've had their supraspinatus tendon retracted, and their muscle has been infiltrated with fat. Okay, so it's not really a muscle anymore. It's just a lipoma. It's just collection of fats. Okay, so of course that is chronic. Okay, it's not acute changes. That takes months, if not years, to develop. Many months, if not years, to develop. So of course, this is a T1. You see it bright. Okay, this is a T2 fat sat because you see it as dark. The fat saturation has nulled the signal in the fat. Okay, and you can see these images in the different planes where that muscle, that supraspinatus muscle, has retracted. So partial thickness tear. Okay, so partial thickness tear, I mentioned earlier, it could be superficial tear. Okay, so it could be on, let's go the other way. So it could be a deep tear. So it could be on the articular side of the supraspinatus tendon. Okay, it could be an intrasubstance tear. So it could be in the middle of the tendon. There's our intrasubstance tear there. Okay, or it could be a superficial tear, which is on the outside of the tendon. Okay, as shown there in the middle. Okay, or the bursa side of the tendon. Okay, so there's the three partial thickness tears. Why do we care? Why do we care? They've got a tear. They're going to need the same treatment. However, if we give intra-articular gadolinium, which is being phased out now, we don't do it so much because we've got increased signal and increased quality of images, mainly from 3T, really. But there are still places where they do intra-articular gadolinium. And that gadolinium is injected, so the contrast is injected into the synovial joint space. Okay. In order to show, one of the clinical indications of intra-articular contrast is to show a rotator cuff tear, but a rotator cuff tear on the articular side. Okay, so of course, what's going to happen there is the doctor's going to inject contrast into this joint space, and that intra-articular contrast is going to go up into that tear. And it's going to show the doctor or whoever's doing the diagnosis, including us, it's going to show that defect there because the contrast is going to seep into that tear if it's on the articular side. Okay. If, however, it's on the bursa side, or if there's a small intrasubstance tear, that contrast that we've injected into the joint space isn't going to make it into that tear. Okay, so we're not going to see it on intra-articular contrast imaging. Okay, so whilst IA-GAD is very good for rotator cuff tears, it's really very good for rotator cuff tears that affect the articular surface of the ligament. Okay, I've said it again, the tendon. Okay, if that tear is not complete and doesn't extend out through the, or it comes from the outside of the supraspinatus tendon, then we're not going to see it in interarticular imaging of the shoulder. Okay. We also have, when we do interarticular imaging of the shoulder, we have a view called ABA. It's abduction, external rotation of the shoulder joint. Okay, so it shows this shoulder joint. This is the shoulder joint in an ABA view, and this shows the shoulder joint really well. Okay, so you can imagine we slice through that shoulder joint, and we can see the structures really well. And there's our tear here. Okay, whereas on the bursa side, we don't see it as well. Okay, the contrast just won't get to a tear up there. And there's the article to read if you're interested. I mentioned tendinosis. Okay, so tendinopathy refers to pathology within the shoulder joint. So that includes tendinitis, inflammation, and tendinosis of the shoulder joint. Okay, so tendinitis, and I mentioned tendinosis refers to damage of a tendon at a cellular level. Okay, so it's got hypercellularity, so increased cells, not rocket science, hypervascularity, increased blood supply, and a lack of inflammatory cells. Okay, so I mentioned this briefly. Tendinitis involves fluid, so we're going to have an increase in T2 signal. Okay, tendinosis doesn't necessarily involve fluid, it's more chronic. So we have an increase in T1 and proton density signal. So that, in other words, the tendon is not inhomogeneous. It's not even, it's not hypointense, okay? It's got hydrogen in it because of blood, because of the cells, increased cells and reaction, okay? So we're going to have less increase on T2 weighted images because there's not a lot of water there, but we're going to have greater increase on T1 and proton density weighted images. So we have a signal, if you can see it there, there's a signal tendinosis in that area of in that tendon, supraspinatus tendon. Okay, and then of course when we do an axial image through that tendon, so a sagittal image of the shoulder, we can see that inflammation there and that increased signal in the shoulder. Okay, and or in particular in the supraspinatus tendon. Okay. I'm going to finish on the labrum and then we'll call it a day for the shoulder until next time. So glenohumeral joint instability. We know that the glenohumeral joint can have chronic dislocations, okay? And in fact, if you dislocate your shoulder once, you can dislocate your shoulder, you can damage, you can increase the laxity or the length or the stretchiness of tendons, and you can also do damage to the labrum. And we know the labrum holds the shoulder in joint. So it's an extension of the glenoid cavity. Okay, I don't know what that means. So the labrum is just an extension. We've got a cavity like so, okay? And of course the humeral head fits in that cavity. If we don't have the labrum, the humeral head can slip out of that cavity, okay? Or if we damage the labrum, the humeral head will come out of that cavity because it's not held in place. If we have a cavity, if we have an increased cavity, we have little labrum here that increases that cavity and a little labrum here that comes out here. And if I was an octopus, I'd be able to show you better. But then we have an increased cavity. We have the labrum will be able to hold that humeral head in place, okay? So it's cartilage tissue, increases the relative depth of the shoulder joints, and it serves to increase stability. Okay. Clinical history of labral tears, trauma or increased force directed through the labrum, may be caused by a dislocated shoulder or gradual wear and tear or overuse. Okay. Swimming, throwing, sports, etc. So we've got three types of labral tear. We've got a superior labrum with anterior to posterior extension. Okay, and this is called, you might have heard of a slap tear. Okay, superior labrum with anterior to posterior extension. Bankart tear and a posterior labral tear. So we'll go through those as well. Okay. So we'll have normal appearance. You can see there that's hypo-intense because it's cartilage. Okay, and that shows it really well. It's hypo-intense structure an extension of that glenohumeral labrum, okay, on all these weightings. Appearance of a normal labrum. What's the difference? Oh, I had a question. Sad, I missed it. And now we have signal in that labrum. Okay, so now we have signal in that labrum. That indicates that it's a torn labrum, or there's some sort of pathology going on in that labrum. Okay, so again, and the slap tear shows it's superior labrum, anterior to posterior extension. Okay, so again, if we inject contrast, this is another good indication for our intra-articular contrast. If we inject contrast into that, then that contrast is going to seep through that labral tear. Okay, and we're going to show it really well on our imaging. Intra-articular contrast, T1 fat set after intra-articular contrast. We're going to inject the contrast into that space, and that contrast is going to seep through the labrum. Different types of slap tears, okay, or different, I beg your pardon, this is different stages of slap tears. Okay, so we've got the superior labrum, that serves in an extension. It's torn at the top. The superior labrum is torn and it may fold down depending on what grade. So this is our slap tear with intra-articular contrast, and that's what I was talking about. The contrast going in and showing us that there's a discontinuity between the labrum and the glenoid cavity. We're nearly there, we're nearly finished. And then there's a Bankard lesion when both the labrum and the capsule along the anterior margin of the glenoid cavity are avulsed. Okay, and you can see that there. Caused by shoulder dislocation, compression fracture of the humeral head from the force of hitting the hard glenoid is called a heel sash lesion. 3/4 of patients with a Bankard lesion will also have a heel sash lesion. Okay, so heel sash lesion is blue, and a Bankard lesion is the red arrow. And you can have a look at that there. One more slide before we call it a day. And then we've got the reverse Bankard tear. Okay. Cause laxity of the capsule at the top back portion of the glenoid ligament. Okay. All right. Any questions? Anything anyone wants to say before we wrap it up? No? All right. Thank you very much. Next time we're going to start. I'm not going to rush through these slides when I know we've got lectures coming up that we can cover this material. Okay, so I apologise that we don't get through the whole lecture, but I think it's better because I like talking. It's better that we cover this next time, and then we'll move on to the knee. Okay, and we should catch up at the end of the knee. We just have a couple of minutes on this. Okay, any questions, any comments, anything that anyone wants to tell me? No.